do those.
Yeah, awesome. Thank you very much. Okay, so thanks for the introduction. As Callum said, I'm Laura. I'm a Senior Public Health Research Officer within Public Health Wales. I'm going to be talking to you today about our project describing unpaid carers' health and health service use in local areas across Wales using linked routinely collected data on behalf of the Network Data Lab Wales team. So just to give you a bit of an overview of what I'll cover, I'll be talking about a little bit of background about who we are as the Network Data Lab and some background on unpaid carers within Wales. I'll then talk a little bit about the data that we have available and what we used for this project. I'll cover the methodology we used to conduct our research, the results we found and any limitations. And then, as Callum said, if you want to drop the questions in the chat as I go through, and we'll come to them at the end. So first up, some background. Who are we as the Network Data Lab? So the Network Data Lab is a collaborative network of analytical teams across the UK working together using linked data sets to address key issues facing health and services today. So funded by the Health Foundation, there are 5 labs across the UK. There's one up in Grampian in Scotland, there's one in Leeds, there's one in Cheshire and Merseyside, there's one in London, and then there's us in Wales. So as the Network Data Lab Wales, we are a collaboration between Public Health Wales, Swansea University, Digital Health and Care Wales, and Social Care Wales. And all of the analysis that we've conducted for this research was done so within the SAIL databank, which is the Secure Anonymised Information Linkage Databank. For anyone who's unfamiliar with this, it's a trusted research environment, and it allows the linkage of anonymised person-level population-scale data. And the SAIL databank contains a wealth of Welsh health data, but the amount of adult social care data held within there is limited. So to give you a little bit of background on unpaid carers in Wales, according to the 2021 census, there's estimated to be around 310,000 unpaid carers in Wales. That's about 1 in 10 for the population. From previous research, unpaid carers are known to have poorer physical and mental health than non-carers. And unpaid carers are a key group in the social care workforce and considered a priority group by Welsh Government. So our work here aligns with Priority 1 of the Welsh Government strategy for unpaid carers, which outlines identifying and valuing unpaid carers. But information on the unpaid carer population at a local level is needed in order to be able to inform support across agencies. However, the main issue with providing this support is highlighted within the strategy for unpaid carers in the difficulty of actually identifying the unpaid carers in order to recognise what support is required and to provide appropriate support to the correct people. So to move on to the data, what data is available in Wales on unpaid carers? So previous research conducted by Public Health Wales and Swansea University used GP data, so clinician recoded codes within primary care data that indicated that an individual provided unpaid care to another individual, alongside National Survey for Wales data for years in which questions were asked regarding unpaid carer status. And these 2 data sources were used to create a cohort of unpaid carers for this previous research. However, we thought, what about the potential of carer assessment data? So unpaid carers are legally entitled to a carer's assessment in order to establish a need for any further support. And local authorities complete these carers assessments for the individuals. The data surrounding carers assessments is routinely collected for administrative purposes by the local authorities that provide them. And an aggregate level of this data is available from Welsh Government. However, individual level data is held by the local authorities and is not centrally available across Wales. And it's this data that we were interested in accessing in order to conduct our research. So as I've touched on, we decided to take a novel approach, and we wanted to look at local authority carer assessment data and the potential for this data to boost unpaid carer research within Wales. So as I said, carers assessment data is held locally by local authorities. There's no central source in Wales, There are 22 local authorities in Wales, so that's 22 different siloed locations for this carers assessment data. So we reached out to as many local authorities as possible, and we ended up partnering with 3 in order to bring their carers assessment data into the SAIL data bank for linkage with wider demographic and health data in order to allow insights into health and health service use of unpaid carers at a local authority level. So these 3 local authorities we partnered with were Denbighshire up in North Wales, and then Neath Talbot and Swansea down here in South Wales. So what was the actual data acquisition process? What steps did we go through in order to get this data from the local authorities? So the first step was just initial engagement. This was as simple as just reaching out to the carers assessment service providers in local authorities, mentioning that we were interested in conducting this research using their data and gauging who would be interested in participating. And then we moved on to the next step, which was to develop aims and objectives. So something important here was that when we initially approached the local authorities, we gave them a very broad aim for our research. We wanted to give them the opportunity to help us shape what specifically we were looking at. So we approached with the broad aim of exploring the potential for research using local authority data to increase an understanding of unpaid carer population and in order to affect their service delivery. We also found pretty early on that it was important to recognise the varied priorities of these service providers. Some of them are focused on daily operational needs, some of them have more long-term strategic goals that they're working towards at the time, so it's important to incorporate all of these things. So our key questions to the service providers were, what information are they keen to uncover? What have they seen maybe in their data that they don't know about? What don't they know already about the people that they are providing support to? Next, it was what types of data are routinely collected by them. This varies by local authorities. There's no standard approach across Wales, so it was important just to know what types of data are actually available. And then the next thing to consider was what data transfer is actually possible. We need to consider the team's ability, the team's capacity, what data could they actually give to us? And then what realistic aims could be achieved with the data that they had available? And finally, what potential impact could these findings have on service delivery? So once we've had these discussions around developing the aims and objectives, the next step was to provisionally agree the data that would be shared. So again, we discussed with the service providers and, where applicable, data controllers within the local authorities. As mentioned, there's a lack of standardisation across the local authorities. So we decided to use a data checklist in order to just be able to keep track of what data was available from which local authority. Another thing we found useful was just being as flexible as possible within the parameters of our project around the data that we required. So we specifically set out essential criteria for data variables, which included the identifiable information about the individual, because this was needed to generate an anonymised linkage field and enable us to link that carers assessment data across other health and services data. And also a carers assessment date was required because we needed some kind of index date to be able to work with for our research. Some local authorities were able to provide further information regarding the carers assessments, which was great, but not essential to be able to participate within the research. We were clear that we were after routinely collected data only. We were not asking local authorities to go out and collect us more data. And then following these discussions, we refined the aims based on the data that they were able to transfer to us and created a provisional statistical analysis plan just to help us show the local authorities what shape the project was taking and what direction we were hoping to be taking the research. After these provisional agreements around data sharing, it was time to actually put it in writing. So we went through the process of creating tripartite agreements between the data controller, which was in this case the local authority, the data recipient, which was SAIL Data Bank, and the data processor, so Digital Health and Care Wales, DHCW. SAIL were great with this. They have a standard template, which very much speeds up the process, but also allows the local authorities to make their own amendments where applicable. The things we found here around sort of factors affecting the approval timelines for this data sharing agreement, it very much varied depending on which local authority we were working with. Each local authority had a unique approval hierarchy, so it had to be signed off at different stages by different people depending on the local authority. There was no one-size-fits-all approach. Also, their familiarity with such processes or prior experience with filling out documents such as data sharing agreements impacted the timelines. Obviously, general operational capacity and any internal priorities at the time of request, so just how much time they had available to dedicate to it, and also data storage infrastructure. So this wasn't something that we'd necessarily considered beforehand, but one of the local authorities we were working with outsourced the data storage of their carers assessment data. So this meant that for the data sharing agreement process, not only did we have to approach the local authority, but they then also had to approach the third party who stores their data. And then after all of these data sharing agreements were in place, the next step was to move on to the data transfer itself. So as I said, aggregate level data is routinely reported to Welsh Government. However, individual level data may not actually be readily accessible to the local authority data controllers. We found there were different factors affecting the timelines for this transfer. So these included the level of data linkage or manual extraction processes required, and these were impacted by both the method by which the data was collected and stored initially, and also expertise within the team in data handling. Again, the general capacity of the teams, how much time was available to dedicate to this, and their familiarity with data transfer processes. Again, the data storage infrastructure impacted here because not only did it elongate the process of signing the data sharing agreements, but for data transfer, it then meant that that third party had to perform the initial extraction in order to transfer the data to the local authority, who then had to transfer on further to Sale and DHCW. And another important factor here was the dynamic nature of data systems. So I've already mentioned that there's no uniform approach across local authorities. Some do use the same data systems, some don't. But local authorities over the study period had also changed the data systems they were using at different times to varying different systems. So this had an impact in the sense that some variables that were previously recorded may no longer be recorded. Data might be stored in two different locations. And in some cases, local authorities were able to amalgamate the information from multiple systems, and in others, the data they were able to provide was dictated by what their current system was. And then following this data transfer, it's over to us for the data exploration and analysis. This was basically just trying to develop an understanding of the data itself. We wanted to get some metadata together. Some local authorities already held this, some we had to create this through conversation. Wanted to check out if there was any obvious linkage issues because this was novel data that hadn't been linked before, and also clarify any anomalies that we found within the data with the local authorities. We also took this opportunity to try and develop a kind of standardized base data set. So although the data collected was different by varying by local authority, we wanted to create as similar a data set as possible to begin with for each local authority. And this also gave us an opportunity to look into the sample size for our cohort. So one of the previous steps of creating a statistical analysis plan, this was provisional, and a lot of the research that we were interested in conducting had the caveat of sample size depending. And we'd previously just been working with estimates from the local authority. So looking into the sample size here allowed us to actually reflect on what level of analysis would be achievable with the sample size we had. So just some quick key learnings if anyone's going to be partaking in some data acquisition. Early engagement, very important to allow them to shape the project and stay interested throughout. Consistent and clear communication so everyone knows what's going on when. allocated time for detailed discussions, we quickly found out that emails may not be the most efficient way to have these conversations. Beginning with minimal data requirements allowed us to have participation from as many local authorities as possible. And also we learned pretty quickly to embrace the flexibility of the process. The timelines will stretch depending on what is going on at the time. And also data may, the data available may vary. So then to move on to our specific methodology. So our objectives after these conversations with local authorities. Firstly, we wanted to describe the quality of data on unpaid carers as identified within local authority carers assessment data and primary care data. So we were also working with primary care data sources. We wanted to describe the demographic characteristics of those who were identified as unpaid carers. And then finally, we wanted to describe the long-term health conditions and health service use of those who were recorded as unpaid carers. So the first step for this was the cohort creation. We had two data sources for identifying unpaid carers. The carers assessment data that was provided by local authorities, and thus we termed these individuals for the purpose of our research local authority or LA identified carers. And then GP read codes within the primary care data, so the clinician recorded codes, and these were termed GP identified carers within our research. The study period was slightly complex because it was LA dependent. It varied depending on what period they had data available for. So for Neath Port Talbot, it was 2017 to 2022, Swansea 1 year from 2021 to 2022, and then Denbighshire 2 years from 2020 to 22. The inclusion criteria for our cohort, we were working with adult social services. So individuals had to be aged 18 plus. They had to have a valid sex within sale of male or female, had to have a valid week of birth, had to be living in the local authority of interest, and then they had to be registered with a Welsh GP for the year prior to their index date and resident in Wales for the year prior to their index date. So these last two were in order for us to be able to look at the health outcomes that I'm going to move on to in the next slide. And in terms of index date, so the date we're working from, this was the earliest date of identification within the study period where all of the above inclusion criteria were met. And this dictated whether an individual was classified for our research as LA identified or GP identified. In terms of outcomes, we wanted to look at health. We were using the 37 conditions from the Cambridge Multimorbidity Score. So we looked at the most common long-term conditions and also a crude measure of multimorbidity of simply 2 or more long-term conditions. And then we also looked at health service use over the year prior to index date. This included GP interactions, emergency department attendances, planned and emergency hospital admissions, and outpatient attendances. So moving on to the results and limitations of our work. So looking at a timeline of the number of unpaid carers who were identified, there was an increase in unpaid carers known to primary care during the COVID-19 pandemic. So the primary care line can be seen in dark purple on this plot. Just as a description of what you're seeing, the vertical black dashed line indicates the start of the study period for each local authority. So within Q1 of 2021, you can see the spike here for all 3 local authorities. And this coincides with the rollout of the vaccination of priority group 6 for COVID-19, and priority group 6 included unpaid carers. So I think that is what's influenced this large spike in Q1. Looking at local authority identified versus GP identified, there was little overlap in the unpaid carer population recorded in the primary care and carers assessment data. Over the 5 years in Neath Port Talbot, we identified just over 2,000 unpaid carers. Over the 1 year in Swansea, just over 900, and the 2 years in Denbighshire, just under 850. And as you can see from these plots, the majority of the unpaid carers were identified using those GP read codes in the primary care records. The overlap, so in terms of individuals who during the study period were recorded as both receiving a carer's assessment and recorded within the GP primary care data as providing unpaid care, was less than 5% of the unpaid carer population for each local authority. And then looking at demographics compared to the general population, unpaid carers were mostly female and from older age groups. And this is as expected from previous research and also what was reported in the 2021 census. However, we also found that the majority of our carers, as a proportion of the general population, were living in areas of lesser deprivation. And this is contrary to findings from the census, which found that the majority of unpaid carers were in the most deprived areas, and actually those within the most deprived areas were providing more unpaid care. So this is interesting in terms of potential inequalities within the support being provided. And then when we look at the local authority compared to the GP identified unpaid carers, local authority unpaid carers were significantly older than GP identified across all three local authorities. And GP identified represented a greater proportion of the younger general population, as can be seen in these plots. In terms of health, so first the multimorbidity rates, which if you remember was that 2 or more long-term conditions. So multimorbidity rates were slightly higher in the local authority identified unpaid carers than the GP identified, although none of these differences were actually significant. And they did reduce when we adjusted for age, so standardized for the age differences between the two cohorts. And then looking at health service use. So health service use by local authority identified unpaid carers was higher than the GP identified. You can see significantly so for planned admissions and outpatient attendances within Neath Port Talbot, indicated by the asterisks. However, these differences were largely due to the older age of the local authority identified unpaid carers. Once we adjusted for the age differences between the two groups, these differences in the secondary care no longer existed. However, looking at GP interactions over the year prior to index date, again, the GP interactions were higher in the local authority identified unpaid carers than GP identified, significantly so in Neath Port Talbot and Denbighshire. However, the rate of GP interactions remained higher in Neath Port Talbot after standardising for age, so adjusting for those age differences, which suggests that age alone can't explain the difference here. And other factors must actually be influencing these higher rates of GP visits. However, exploring exactly what these factors may be was actually beyond the scope of this project. So just in summary of the results, there was an increase in unpaid carers known to primary care during the COVID-19 pandemic with that spike in Q1. There was little overlap in the unpaid carer population who were recorded in primary care and care assessment data. Unpaid carers were older than the general population, with a greater proportion of females and actually living in less deprived areas for our cohort. And health service use by local authority identified unpaid carers was higher than GP identified, but this was largely due to the older age of local authority identified carers. So if we move on to some considerations, why are the differences in the local authority and GP identified cohorts? So one of the possibilities is that this could reflect distinct population needs and levels of support required. It may reflect that services are actually reaching those who need them. So older individuals may require that support from local authorities, whilst it's the younger individuals who require the GP support. However, it may also indicate a gap in support for younger unpaid carers. And from the data available for this research, we're unable to determine which is most likely. It may also reflect systemic differences in data collection, coverage, and quality. So local authority and GP data, they're recorded for administrative purposes of the service. They aren't intended for the identification of unpaid carers. In terms of limitations and further considerations, so we didn't have any indication of when an individual actually started or stopped providing caring duties. All we've got is that initial identification date. The use of GP codes, so for those GP identified individuals in primary care, varies by the consultation context, by the specific GP, and also by the GP practice. We also didn't have any data of those who were on the waiting list for a carers assessment from the local authority, those who'd refused a carers assessment, nor of the actual assessment outcomes from those individuals who received it. So in summary here, it's difficult through routinely collected data to identify unpaid carers and to inform plans to support them. And this suggests a need to have a more integrated system for supporting unpaid carers in order to ensure that they receive the support they need. So in terms of publications for this work, we have a Network Data Lab Wales publication, which is available on the Public Health Wales website. I've included the link here. And there's also a couple of additional publications from the Health Foundation. So the top one there provides sort of background on the picture for unpaid care within the UK. And then the bottom provides a report that covers the results of 4 of the network data labs who looked into unpaid carers. So I've covered what our findings were, and yes, that's interesting, but what is the actual added value of our work on unpaid carers? What's the so what of conducting this research? So we approached some of the people we'd worked with and asked them to let us know what they intend to do and how this research would impact their work. So Sarah Waite from Neath Port Talbot Local Authority told us that the research has informed and supported a local review into unpaid carers. It helps start the conversation with their primary care colleagues about strengthening pathways of identification and support to facilitate a more preventative and early intervention approach. Tim Banks from Carers Trust Wales said that the research shines a light on the impactful possibilities when it comes to recognising unpaid carers at the local level. It was fascinating to see distinct populations between primary care and care assessment data. And this research plays a vital role in showing the inverse care law still holding true. This serves as a timely reminder of the need for services to ensure all carers are supported in an equitable way. And finally, Jake Smith from Carers Wales. This research represents a valuable contribution to our understanding of the unpaid carer population. By combining local authority and NHS datasets, this research shines a light on the issue of carer identification and serves as motivation for a renewed focus on collaborative working to deliver improved identification and support for unpaid carers. So that's it for the majority of my presentation. I wanted to just throw out some acknowledgements while I've got you. So I've already said we're funded by the Health Foundation and that Network Data Lab Wales is a collaboration across Public Health Wales, Swansea University, DHCW and Social Care Wales. But I want to give specific thanks to individuals from Neath Port Talbot Local Authority, so Jan and Marion, Swansea Local Authority, Catherine, Andrew and Rachel, Gwynedd, Linda, Dave and Mark and Rodri, Denbighshire, Alison and Dyfan, and Newcastle, Michael, who provided both data and expert insight for this analysis, and it would not have been possible without them. So thank you very much for listening to me. Any questions? And there is my email, so please get in touch if you would like to.